Okay, so today I would like to talk to you about gold standard guidelines for COPD care. Now, the gold guidelines are guidelines released in 2013. They're guidelines that most family doctors follow. Pulmonologists add a bit more things onto them, but they follow these as well. Just some disclosure, the research was in part funded by pharmaceutical companies, but it's where money comes from now. So the gold guidelines have an A, B, and a C, D category for classifying where your patient is with their COPD. Is it very severe or is it not that severe? So A, B, C, D. And then based on that, it talks about what the treatments are. So if you've watched my video on asthma, the big changes between asthma treatment and COPD treatment in general, being emphysema and chronic bronchitis, are going to be anticholinergics. So anticholinergics you would most likely not be using in a patient with asthma, but you would be using it for a patient with COPD almost all the time. The only problem is that they are pretty expensive, just like every medication in respiratory. So the short-acting anticholinergics are piratropium, which is Atrovent, and then the long-acting are tropium, which is Spiriva, and acelatropium, which nobody knows the brand name for that. I can tell you what won't ring any bells. So these medications are really good, particularly for people with COPD. However, they do have a large side effect profile. So they can cause just a general drying effect on the body. So they can cause urinary retention, dry mouth, blurred vision. So gotta think about the elderly when we're giving these medications. Somebody with BPH, you don't want to give an anticholinergic to because it's going to cause even more urinary retention. Somebody who has glaucoma, you don't want to give an anticholinergic to because it's going to cause blurred vision. And then you might just have some patients complaining about different general symptoms that sound a little more than our usual medications, but just know that is to be expected. So COPD, we diagnose it with spirometry. We only do spirometry though when the patient is not in an exacerbation. If the patient can't breathe, do not try to do spirometry on it. I know that some pulmonary offices don't try to do spirometry on the patient. I know that some pulmonary offices do this. However, it is no longer a recommended treatment. It used to be, you get the patient in, they're having an exacerbation, you do an spirometry, find their forced expiratory volume, do a neb treatment, then test it again, see if they're doing better now. No, we know that just wears the patient out and works against the treatment that we're trying to give, so don't do that. So a forced expiratory volume of less than 0.7 is going to be adequate for a diagnosis of COPD. If you have mild COPD, you might have 0.8 or above. If you have moderate COPD, you're going to have 50 to 0.5 to 0.8. If you have severe, you're going to have 0.3 to 0.5, and then less than 0.3 is the very severe category. So just kind of have that in your mind, but it's not always, numbers are numbers, but you've got to see how your patient is presenting and look at the big picture, which is why the ABCD gold standard is so nice, because it takes into account airflow restriction, which is the FEV score, the symptom score, which we do with there are two different types of testing we can do for that, but The main one is the CAT score, and it kind of just asks you what symptoms you're having and how often. And then the number of exacerbations you've had. So just 1, 2, 3, 4 in the past however many days. So treatments in general for all patients are going to be stop smoking. Make sure we're giving them their pneumonia vaccine and their influenza vaccine. Pulmonary rehab. The only people this is not appropriate for is A. Now, COPD is a really life-changing diagnosis. Waking up every day and not being able to breathe very well is really rough. So pulmonary rehab is something a lot of patients really like because they get to have somebody to kind of talk to and discuss challenges with. They get their physical therapy, they get their occupational therapy, and they come out doing a lot better. They have a lot of classes about their COPD. They have a lot of classes about stopping smoking, everything under the sun, which can take a lot of work off of you as the provider. People in our group B, which is, a decreased functional status, not too many exacerbations and not too much airflow limitations. Those people are going to need a long-acting beta agonist or a long-acting anticholinergic. The people in C and D, they have more exacerbations, more airflow limitations, but their functional status can be wherever. These people are going to need either a long-acting anticholinergic or an inhaled corticosteroid and a LABA. In addition to the short-acting PRN treatment, which is going to be the short-acting anticholinergic or the SABA. So again, the short-acting anticholinergic is Atrovent, which is ipratropium, and they could also have albuterol, which would be the SABA. When you see these patients, they're going to have progressive dyspnea. It's going to happen over time that, eventually they're dyspneic even when they're just sitting and doing nothing. But at the beginning, it's going to be really more related to moving a lot and a lot of activity. They're going to have a chronic cough. And this varies. So those with bronchitis are going to have a lot of sputum production, and it's going to be all kinds of colors. And those with emphysema, it's really going to be more of a dry cough. And then, yeah, so I think that's pretty good coverage of the of patients with COPD. Go back and look at asthma guidelines, which are in a video previous to this one, and I hope this has been really helpful in treating those patients. They are complicated, so just stay on top of them. You want to see them like every 2 months just to talk about their symptoms, see where they are, restage them, make sure their treatment's accurate, and then go ahead and get those pulmonary function tests like about once a year. All right, thanks so much. Bye.